Wonderful. So thank you so much for joining us today for this webinar on the importance of social connection for older adults during COVID-19. My name is Ariel Mather, and I'm the program manager for the National Center for Equitable Care for Elders. This presentation today will be led by Dr. Peter Miramaldi, who is a wonderful member of our team. I'd love to read a short bio for you now. Dr. Miramaldi is a professor and former director of the Social Work PhD program at Simmons University College of Social Sciences, Policy and Practice. He's also an adjunct professor at the Harvard T.H. Chan School of Public Health in the Department of Social and Behavioral Science, as well as a clinical instructor at the Harvard School of Dental Medicine in oral health policy and epidemiology. His extensive consulting work in evidence-based health promotion across disciplines addresses individual needs through population interventions. He has previously consulted on HRSA-funded projects to train dental residents on how to include social determinants of health and how to communicate more effectively with patients and families. His most recent national project focused on optimizing health teams' provision of healthcare to frail elders living in the community. As a social work behavioral scientist, he works with physicians, nurses, health economists, and caregivers to determine the most cost-effective models of interprofessional healthcare to frail elders living in the community. So we are so excited for Dr. Miramaldi to lead this presentation today. Before we get started, I do want to just mention, if you're not familiar with our center or our activities, a special welcome to you. We are a national training and technical assistance partner through HRSA to provide these types of learning opportunities to health centers and lookalike facilities across the country. We do hope you'll stay connected with us. There's a variety of links on this slide. We hope that you'll join our future training activities as well. And certainly during this very uncertain time, there are a lot of resources now out there for health centers and other organizations looking to address the various needs of their patients of all ages, but including older adults. So if you're not familiar with the Health Center Resource Clearinghouse, I highly encourage you to check out their priority topics page for COVID-19, which has a wonderful list of resources that are growing every day. And a few reminders. We're all very familiar with Zoom by this point, but just another reminder that we are muting all lines to prevent echo and background noise. We do hope that you'll participate in this session though, through the chat box or Q&A feature. You will receive a link well, you can certainly check out the recording on our website when it's available, but you'll receive the PDF of the slides right after this session closes. And we, of course, would love to hear your feedback. So our evaluation link will pop up when you close out of this webinar. We'll also make that link available via email. We would love to hear your thoughts, not only on this session, but perhaps for other future topics for training and technical assistance activities. So with that, I will turn it over to Dr. Miramaldi.
Thank you very much, Ariel. It's a pleasure to be here. I'm coming to you from my home in the suburbs of Boston with a house full of people working remotely, including a high schooler and a middle schooler. So welcome, everyone. These slides are going to be very content rich, and just about every slide has a link to it, and everything is public access. And the reason I do that is that I noticed a number of you are intending to use these materials to bring back to your organizations, to your teams, to your staffs. Some of you may want to use them in training, but they will be very content rich. Next slide, please, Ariel. So today, these are our objectives. You signed up for this, so you know this. But first, we're going to look at the effects of social isolation and loneliness. Then we're going to look at some ageism issues that are very disturbing that have come up during the pandemic. And then we're going to start talking about how we can address some of these issues. Next slide, please, Ariel. So let's talk about, who are we talking about? Next slide, please, Ariel. So here are the generations as we think about them broken down. And you can see the proportion of this silent generation. Next slide, please, Ariel. This is a better depiction. And if you look at this, you see that this greatest generation, these wonderful old people who raised some of us, are really dwindling off, and they are very vulnerable in some cases, but in other cases, they're extraordinarily resilient. And that's something that we all have to keep in mind. Next slide, please, Ariel. I would direct you, if you're interested, if you haven't seen this already, this is a wonderful resource brought to you by the federal government. And every year this gets updated, and it's a really data-rich description of older Americans in the United States. Of relevance to this discussion today, next slide, please, Ariel. You'll see that the number of people living alone, this is a type of data that you'll find in here, but living alone is certainly a risk factor for isolation. And we can see this in reports like this, but there are other considerations as well that we'll describe. Next slide, please, Ariel. So, so the idea that COVID is a disease affecting the elders, I think most of us understand this, but here's a breakdown, and this might be an interesting way to think about this, that young people are affected well. And these are just the ratio compared to 18 to 29-year-olds. You can see the comparison group is the second group of bubbles on the row. And you can see the degree to which people are at risk. This is a wonderful, if you want to hang this up somewhere, just from the CDC, this is a wonderful infographic. Next slide, please, Ariel. Many of you are aware of this. These data may be fluctuating now, but these kinds of infographics can be very powerful. This notion of 8 out of 10 deaths attributed to people 65 and older contributes to the ageism that we're going to be talking about. Next slide, please, Ariel. But in reality, old people are, die more anyway. And this idea that, there's not much difference between all deaths in this age group, between COVID-related deaths and all other deaths. Next slide, please. If you think about it, 1 in every 7 Americans is an older adult as of 2018. This is, changes slightly. And 1 in 10 live below the poverty level. What I'm always interested in is not only those below the poverty level, but it's those working poor as well. And if you look at the racial compositions, you can see that we've moved from 2008, 19%, to 2018 to 23%, almost a quarter of older people in the United States self-identify as members of a racial or an ethnic minority group. And you can see here the breakdown, and the majority are either African Americans or people of Hispanic origin who could be of any race, represent the other large amount of these minority populations. A lot of you in FQHCs and health centers are working with these populations, probably in greater proportions than in different parts of the country. Next slide, please, Ariel. So here we see what is really concerning about the inequities. If you look here, this infographic's pretty straightforward, but these are rate ratios in comparison to white non-Hispanic persons. And you can see that the American Indian, Alaska Native, non-Hispanic people have very, very high rates of cases and hospitalizations. And the 1.4 times higher death rate is concerning, but the highest death rates are among African American non-Hispanic populations. And I think these are the populations that many of you are working with. Next slide. So this is no news. I'm going to go through this, and you may know this already, but there's a rich literature. Next slide, please, Ariel, on the impact of isolation and loneliness. So let's start by being crystal clear about what we're talking about. Social isolation, you can read these, but social isolation is considered to be an objective state of having fewer relationships, social relationships, contacts, interactions with people, compared to loneliness, which is a very subjective feeling of being isolated. One can be in a crowd and still feel lonely. One could be in a 5-generation household and still feel lonely. So it's just very important to make that distinction. Next slide, please. This is nothing new. The Surgeon General declared an epidemic of loneliness, and I'll show you some of the data that led to that in a minute, in 2017. But what's concerning about it is that, and you've probably seen this already, but we can see that people are at much greater risk for cardiovascular disease, dementia, depression, anxiety. It's a very, very important public health consideration. the same as smoking cigarettes. I mean, we're hands down, we understand this. Now, with COVID, we may be more attuned to the impact of social isolation and loneliness because many of us are experiencing it. But it's something that there's pretty strong evidence to suggest this is an important public health concern that has to be addressed now, and especially for older populations. Next slide, please. The HRSA webpage, always an excellent source of information, but you can see here the percentages of people that are feeling lonely. Now, this is pre-COVID data. These data are before COVID, and that's very important to consider. And the loneliness, the idea that it has the same impact of smoking 15 cigarettes a day is pretty powerful when we put this all in context. Next slide, please, Ariel. And again, before COVID, because of this declaration of a loneliness epidemic in the United States, the National Academies of Science, Engineering, and Medicine commissioned a consensus study. And I would strongly recommend, if you're interested, this is free, it's your tax dollars at work. You can download this, you can get a free PDF version online and take a look at it. But it really summarizes the evidence, what we know now. And we go to adults 50 and older. Next slide, please, Ariel. So some of the major findings, and 24% of community dwelling Americans are socially isolated. That's a quarter of Americans reported being socially isolated. The data aren't in yet. I mean, there's preliminary data, but that's, the number's very likely to be increased significantly with COVID. And you can read through these, but you can see there's almost a 30% increased risk of all-cause mortality and 25% risk for cancer deaths. So, we think about cancer almost as a chronic disease now, but it's a life-threatening disease that has to be taken seriously. And this notion of isolation and loneliness being a risk factor is in those cases is important to consider. So if you think about it, what populations are going to be more, and we're talking about disparities here, lesbian, gay, bisexual population experience loneliness more often because of stigma, discrimination, barriers to care. First generation immigrants experience stressors that increase their social isolation. There's language barriers, cultural barriers, community barriers. I mean, I have neighbors, Asian neighbors, who each has an elder living in the house, and they're completely isolated. And when the families used to go to work, when they go off to work, they're alone all day. It's something to consider, especially when people come from larger families. And these are the populations that many of you are serving in health centers. And you probably know more about this than I. I'm looking at it, you're seeing it in a different perspective than I. Though I do visit a lot of health centers, and I'm always amazed at the work that's being done. It's something that we have to think about, and at the same time, we have to avoid stereotyping. Next slide, please, Ariel, and I'll talk about that in a little bit. So let's step back and look at what the literature tells us about the health effects of social isolation and loneliness. High blood pressure, heart disease. If by contrast, people who feel connected have better health outcomes. And the data's in on this. The NIA data, there's several research studies on now. We had several COVID studies underway right now from multiple funding sources. And these data will be very interesting to watch out for in the future. Next slide, please, Ariel. So these are some of the life transitions that the literature and our clinical experience, I can tell you my own clinical experience and my own life experience tells me that really increase the potential impact of isolation and loneliness. You can read these, but think about the idea of changing finances right now. So many people in our country are suffering financially. And if this is going to increase a lot of what's happening with COVID, these acute illnesses, COVID as an illness, it's not even that one has to be, this is different now. It's not that one has to be infected with COVID, but it's the impact, it's the fallout of COVID that is affecting everyone. And this is going to feed into some ageism as well. Next slide, please. So this is the article that drove so much recognition. And Julianne Holt-Lund at Brigham Young did a very impressive review of the literature, and she did some meta-analysis. And from these reviews, these are the risk factors: living alone, being unmarried, single, divorced, or widowed, not participating in any kind of social groups, having fewer friends, and strained relationships. These are the identified risks for loneliness. In fact, they're in there, COVID, and it just geometrically increases each one of those risk factors. Next slide, please, Ariel. And then there was a meta-analysis that the same group did, and this idea of the risk for mortality as a result of poor social relationships is comparable to other very well-established risk factors. Next slide, please. So if you take a look at this slide, I know it's hard to read and I apologize for that, but the top bar is social relationships findings from this meta-analysis. And the longer the bar, the greater the odds ratio, the impact, the effect of social isolation on mortality. So you can see here, these next two bars from the top, bars 2 and 3 from the top, are about social relationships and social support and social integration, higher than the ones below it. The fourth one down is smoking, and you can go all the way down the list. And this is a culmination of many studies in this article. It's a terrific article if you're interested in it. The idea is that there's pretty solid evidence here that social relationships, senses of belonging, isolation are very important considerations in health. Next slide, please. So now let's talk about ageism. Next slide, please. And this idea of devaluing older adults. These are some quotes that I chose. And if you think about it, age discrimination, ageism, it's prejudice by one age group toward another group. And if you look at the third quote, it's the middle-aged upon whom this burden is imposed from both ends of the life cycle. We often talk about sandwich generations. You're worrying about raising children, educating children, maintaining one's own life, and then taking care of one's elders. And in some families with 4 and 5 generations, that's even more intense. I don't know if these resonate with you, but this idea that the young doesn't trust people over 30, but those over 30 might not trust anyone younger. These are these dichotomies, these tensions, this acrimony between generations that really doesn't do our country, our culture, our society, and this is true around the world, any good. Now, we argue too that it could be 40 even. Next slide, please. What's interesting to me is those quotes were written in 1969 by Bob Butler. 1969, a period in our nation's of history where there's enormous turmoil. It's similar to what's happening today. And this idea of ageism was identified then and still holds true today. It's a very interesting read. It's dated in many ways, but it's an interesting read if you're interested, and there's a link for it. Next slide, please. And here's another systematic review of the literature that I find absolutely fascinating, and it's this global reach of ageism. And there were 13,000 papers screened, 638 were reviewed in full for admission, inclusion criteria in the study, and 422 published papers in academic journals and gray literature were reviewed. And the idea and what the findings were that ageism led to worse health outcomes in 95% of the studies that were reviewed. And this included 7 million participants in these studies. And what was also very important to consider is that people with less education were particularly likely to experience adverse health effects related to ageism. Next slide, please, Ariel. What's the problem with all this? So the idea of assuming that all old people are the same, that all old people are defenseless, that all people in older groups need protection is a false assumption. Some people age differently than others. There's people who are 70 who are more vibrant than people who are 50 or 40 years old even. And I think you all probably know people like that. So this, it's a false assumption. The other idea is that, will older people not receive adequate treatment? This is something that we're thinking about a lot with COVID. Before COVID, we thought about that. Now more than ever. And this, this warning for older people, regardless of health status, social isolation, because of the way societies responded to the COVID epidemic, is all older people are at higher risk, regardless of their health status. And if, people are being disenfranchised, and older people especially aren't likely to come forward with their emotional or mental health concerns, there's an increased risk for more severe mental health issues, including suicide risk. And then and this is a Lancet article, and it's a very interesting piece. I think that you should take a look at it if you're interested in any of these. This notion that we're going to minimize the importance of older adults' mental health. Given everything that's happened now, can we really afford to minimize the mental health needs of older adults? So do we continue screening? Are we, we're hearing a lot about screening for preventable diseases like breast cancer and colorectal cancer. And, I hear a lot of public health messages here in the Boston area to continue seeing my primary care physician. Are we doing likewise with mental health issues? In reality, a lot of behavioral health centers are really just completely overwhelmed by the demand right now. But are we still reaching out? What's happening in your centers? Next slide, please, Ariel. This is a terrific article I highly recommend from the gerontologist. And the idea here is that the pandemic, parallel to the pandemic, came this new wave of ageism. Ageism first appeared in literature in '69, but the pandemic, all of a sudden, we started to see a lot more of it. And this language, and we were already divided as societies, and a lot of it has to do with age as well. But younger people are tending to direct their anger and resentment toward older people. Before the pandemic, we saw this notion of millennials saying that the older people took everything. And in reality, boomers are going to be the wealthiest generation in the history of our country. They have accumulated more wealth, and the millennials are, and you all know this, millennials are struggling to find a foothold in our society. And these generalized description. And what's most concerning, will age become the accepted criteria for triage, or should we be thinking about this in advance? Next slide, please. So these kinds of considerations resulted in the journal Age and Aging. There was a commentary by 20 international researchers, most of whom were from Canada. And this is what their findings were, that we're devaluing older adults, that some people wrongly think that the pandemic is an older person's problem when it's not. And we saw that on the earlier CDC slide. And that it's very important that we think about and try to strive for intergenerational solidarity in order to really maximize support and connectedness during this pandemic. Next slide, please, Ariel. And there's a lot of empirical evidence to the devaluation of older people. This is a study that's being done. It's a fascinating study. It's out of MIT, but it's a study that it's an old, those of you who remember from your psychology courses, there was a study of the conductor when he of a streetcar conductor, when he should move the switch. If a trolley is who is going to injure, which way would he move the switch? It's and would hurt older people or younger people, men or women. And here, this is 40 million decisions have been recorded so far, 233 countries. And interestingly, older men and women, and you can see on this little chart here on the bottom photo picture, the decision is which way would you turn your wheel? Would you hit those people, and they're depicted in different constellations, or would you hit the wall? And if you hit the wall, you might injure the people in the car. But older men and women were the least likely to be spared, and they came just above dogs, human criminals, and cats. And there was generally in all countries a preference to save young, and you can see here on the slide, there was a weaker preference in some East Asian and Muslim countries, but there was still a preference to save young in each of these. Next slide, please. And my high schooler tells me that this is old news, but I still find it very disturbing. Hashtag boomer remover, where millennials were talking about COVID-19 epidemic as the boomer remover. You know, for someone like me, who's a gerontologist, this is simply disgraceful. But you can see the kinds of tensions. You know, and if you're, I don't know if you're familiar with any of this, or if you've heard of any of this from younger people. There's a literature coming out of India as well. And it's like Uncle Sit Down, and it exposes these kinds of tensions between generations. Next slide, please. So this is back to the earlier article I mentioned in the Gerontologist about this parallel rise of ageism. So it's important. These are things that we can do, what we have learned from the behavioral sciences. We have to do whatever we can to stem this parallel outbreak of ageism, even if it's people you work with or people in your personal life or your professional life. If you see these kinds of comments, negative comments, dispersions, these kinds of ageist comments, to take note of that and call people on it in a way that's not a 2x4 in the face, but in a way that's going to help them understand the importance of valuing, to evaluate this notion of intergenerational solidarity. Because, you know, we have to social distance doesn't mean that we have to be so far away from each other. And, you know, people are finding ways to do that. It's important to include older people. You know, while we're saying computers are great and social media is great, there's a lot of problems with social media. It's really easy to go into this notion of, you know, hashtag boomer remover, rather than saying, let's figure out how I can contact this older person in my neighborhood, how I can contact or make sure that everybody in my church group or my synagogue or my mosque, everybody is looking out for the elders in the community. And this is very important, and I'm sure many of you have discussed this already, and this is something that's playing out, unfortunately, all over the country right now. But it's important for us to, in advance, establish triage ethics during COVID. And if chronological age is going to be the criteria for treatment, some of us argue that that's ageism, and maybe there should be other considerations as well. And these, maybe you're having these discussions on your teams, but these are tough issues to deal with. Next slide, please.
Dr. Miramaldi, just before we go on, I know that there was a question slash comment in the Q&A just around your comment around the baby boomer generation accumulating wealth, but also acknowledging the increasing wealth gap between white individuals and minority populations. I didn't know if you wanted to address that.
Absolutely. It's the wealth gap is worsening. I didn't put econ data in here, but you know, this wealth gap is only going to contribute as income breaks in income, and this data where 1 in 10 earlier that I mentioned, elders lives below the poverty line. The data, if you look at it down racial and ethnic dimensions, is different. It's always hard to collect these data. Did someone have a comment to make, or is it a question? Like, we welcome comments as well.
Yeah, I mean, so I think more the question was when you said that that baby boomers had accumulated the most wealth, they were just clarifying if you meant white baby boomers, and then mentioned.
I see. Yeah, predominantly, yes. Yes, predominantly. I hope that answers the question. If not, please put it back in the chat. I'm including these slides, but I'm not going to spend a lot of time on them. And it's if you're interested in, this is an interesting paper. I'm always concerned about stereotyping for these kinds of findings. But this notion of familialism is important, and familial obligations, support, perceptions of support, and how it plays out across different groups. You can take a look at these, but these are very interesting articles. And if you're interested in population-specific programs, I would recommend that you work locally, but also you can grab on some of this literature. A lot of it's old now as well. Next slide, please. This is an interesting article I would recommend. It's a study of 123 ethnic minority elders in Canada, but it's a really clear, it helps, and if you want to do some PDSAs, or if you want to start looking at improvement approaches in your own clinics, it helps you identify concepts in an article like this to be crystal clear on what you're talking about. That's so important. Next slide, please, Ariel. There's a lot of conflicting evidence, and I've included some here for you to take a look at. I would, if you're interested, I would recommend that you spend some time and look at these. But you can see how old some of this is. It may not be relevant anymore, but I'm always interested in the way the approaches people had to making these observations. Next slide, please, Ariel. And here's more about social networks, and you can just go through these in greater detail and see that there's a lot of assumptions about different groups. But I do a lot of work in culture, and what's really important to remember that in addition to culture, there's also personality, and there's also a worldview, and that worldview is changed with daily experiences. So it's very important not to stereotype when you start reading these types of studies. Next slide, please. The most important thing is to just ask people. Those of you working with Asian populations, you might find some of these studies interesting, well dated. But this, the Wu and Penning article is interesting, where second-generation immigrants reported higher levels of loneliness than native-born Canadians. That's really interesting. Next slide, please. So let's talk about approaches and what can we do now. There was a health forum piece in JAMA in June, and we think about it, we step back, we think about primary, secondary, and tertiary prevention measures. And we trying to identify risk factors as potential barriers. And if you think about sensory impairments, that can include language, but hearing loss, what happens if somebody's hearing aid, they lose their batteries now, those sorts of things. Just basic stuff that we can do when people are coming into primary care. And then this notion of secondary prevention. Should we screen everybody, or should we use clinical judgment to decide who gets screened for isolation, or who gets screened for loneliness, and who would benefit from an assessment? That's really important. And then this notion of, to expand surveillance. And I'm gonna show you some possible ways to do this in the next few slides. Next slide, please, Ariel. Here's an example of United Healthcare Foundation, which is an interesting program. I don't know if you're familiar with it. Some of you probably are. But the idea is this power of partnership and collaboration in communities. The idea that all healthcare is local, to involve communities in healthcare, rather than going to this literature at 30,000 feet, using that literature to frame as a frame to try to understand some of those concepts, to try to understand how we could view, because sometimes when we go into a community, it's like melting ice cream. There's so much information flowing, but it's a way to frame and hold things. It's like putting a container on everything so you can observe it. Once you can do that, then hopefully with this kinds of partnerships, you can create a workforce that can address the needs of the community at a level that the community will benefit most. And we have restrictions. We have funding restrictions. We have structural restrictions. We have staffing restrictions. But the idea is to be creative here in this whole person health. Next slide, please, Ariel. UHF releases a lot of information. Here's a paper they did. And if you see the next slide, please, Ariel, you'll see how this incidence of risk factors, how they use these data. And, this is between 2013 and 2017. But yeah, how many people have these risk factors of disability? How many people live alone? What proportion of people live alone? People over 65. How many are divorced, never married? It's poverty level. My guess is those poverty levels are going to increase significantly now. We'll see what happens. And homebound, which is interesting. But, the question is, do you screen for these risk factors in your center? And the idea is that if you're working with a community group, you can work with the community group to ask how to ask these questions. What's the best way to ask this question in a way that is face-saving for the community, a way that is more likely to get a response, a way that is respectful, that is socially and culturally appropriate to ask these kinds of questions. And you get these questions answered and you have an idea of who's at risk. I hope that makes sense. Next slide, please, Ariel. And then if we go again to this, the National Academy's consensus study on social isolation and loneliness, these were the major recommendations they came out to in terms of what we can do. And that is to conduct assessments to identify at-risk individuals, include social isolation in the EHRs. Those of you who have electronic health records, do you collect data on isolation? Maybe, I think more people are going to be doing this, but part of the problem is collecting data on social isolation. If you have these data, are you exposing your institution by not having an opportunity to address the need? That's always something I come into in my consultations. It's like, yeah, we can screen for this, but if we have a positive hit, what can we do? And if we don't do anything and we've identified a need, are we increasing exposure here? Are we risking things for the organization, for the institution? It's something to consider. And then that's why this notion, can we go back, please, yeah, this notion of being prepared. How can you connect? If you screen, how do you connect people? And it's really interesting. I put a slide in here later. It's like in the UK, they talk about social prescriptions. We know how to prescribe medication. We know how to prescribe adaptive equipment. We know how to prescribe appliances, but do we know how to prescribe social care? And that's really interesting. And it's not just a referral to behavioral health. It's connecting people with resources in their communities. Next slide, please, Ariel. So I've included each one, a little description of each one of these, and I'm not going to spend a lot of time on them, but these are the ones that came out of the consensus study of the National Academies. And, do you use any of these in your screening? It's interesting. We often use these in research, and I'll just give you a little taste of them, and I want to express some concerns about them that were actually articulated in the consensus study. Next slide, please, Ariel. So this is the Berkman SEAM social network. These are the kinds of questions you would get in these. Now, a lot of folks ask these questions informally, or they might be, clinician to clinician. It may vary. Someone may ask a similar type of question, someone may not. The idea, if you're asking these questions, or we're recording them, but if we're asking them in a systematic way, that everybody, that we in that the notion of this secondary preventive approach, who should we screen? If somebody's older, if they're living alone, if they've had one of those risk factors, should we employ a screening mechanism? And if we do, is it systematic? Next slide, please, Ariel. This people like 3-item scales because we were all very busy and we have a lot of questions we're asking in 12 or 15 minutes. And hopefully we have more time than that. But this notion of how often do you feel, and you see how these are subjective questions. How often do you feel left out? And how often do you feel isolated from others? These sorts of questions are very effective. But I'm going to show you something newer that people I'm leaning toward. Some of these are also proprietary. So depending upon your institution, your organization, or your clinic, or wherever you're working, you may or may not have access to these. Let's just go through the next couple of slides, please, Ariel. Okay, and these will be in the slide deck if you're interested. Please, Ariel, go ahead. You hear in the literature, you see a lot of use of the Duke social network scale. Can you go back one, please, to the Lubin? Jim Lubin's a friend of mine, and he helped me when I was coming up. So I just have to take a moment and pause and acknowledge the Lubin social network scale for a little commercial break. Next slide, please. Next slide, please. And next one. So here's the concerns. Oh, one after this, sorry. Many of these are 10 or 20 years old. And think about how much society has changed in 10 or 20 years, 10 or 20 years. And then factor into that COVID. I mean, are these going to be effective measures? In many cases, I would argue yes, but and the idea of these trend studies, we're going to violate people's privacy. And if you think about it, if you did a study of, say, a certain group in a certain urban area, you could bring great shame to that group of elders if their perceptions were reported they were isolated, even though they were living with their families. That could be face losing for them. That could be this notion of these harmful stereotypes. It's very, very important to consider that. And you can read through these, but the idea of populations at risk, low income, minority, LGBT, disproportionately impacted by all of this. If we only assess those populations for social isolation and loneliness, we'd be almost targeting them. So there's ethical considerations there as well. And this is all right, it's well articulated in the National Academy study. But next slide, please, Ariel. This campaign to end loneliness out of the UK, it's very interesting. And these are some questions, if you are screening and if you're not screening, that are important to ask. If you're going to be doing training, this would be something valuable to bring back to your team. Are you comfortable asking about these very direct questions, loneliness or painful experiences? Do you have time to ask these? And if you don't have time, what has to be, what can you take out of the interview in order to include these? Who's going to ask these questions? How are they going to be recorded? Who's going to analyze them? What I said earlier, if you're addressing the social dimensions of loneliness, or are you going to think about the psychological dimensions? Will you have resources to provide mental health services if you're screening for that? And how much time do you want to, and money do you want to devote to this? These are important questions. Next slide, please. And these are things to consider. This idea that, how much time do you have? How long can you take to ask questions? Do you do it negatively or positively? This is where the United Health Foundation approach I showed you is involve community members. What's a good way to ask this, maybe? Can you ask the question directly? Next slide, please. So here's from the Campaign to End Loneliness, some recommendations of scales that you might use. And you can see the key points they're asking: length, language, initially developed for what, and does it mention loneliness? And two of these are meant to initially develop for researchers and two for service providers. So as a service provider, you may be more interested in those, but at the same time, you may benefit from the research ones. And I'm going to show you the Campaign to End Loneliness scale. Next slide, please, Ariel. 3 questions. I'm content with my friendships and relationships, and this is free access to this. Had enough people I feel comfortable asking for help over time, and my relationships are satisfying as I want them to be. And if you go to the next slide, you can see how to score, and there's the scoring mechanisms. And that's how you score it. It's very straightforward. Now, you could, how much time would it take to do this? Would people, if you wanted to do this, if you're not doing something already, is this something that might be implemented? But then the question becomes, what do you do when you get, you detect loneliness, especially in older populations? Next slide, please, Ariel. I mentioned this earlier, these social notion of social prescriptions. We call them referrals, but if you think about it as a prescription with the same kind of thoughtfulness and precision and evidence-based direction that you would write a prescription for out of the pharmacy, what are you going to take out of the behavioral health department? How are you going to send people? The trick is maybe it's not the within house, but maybe it's relationships and referrals outside. And that's what I want to show you. Next slide, please. So these are very rich federal resources. Many of you probably work already with the AAAs, the Area Agencies on Aging. And this all came out of the Older Americans Act in 1965, I believe. And the idea here is that if you go to these web pages, you can plug in numbers and they'll send you to referrals and connect you with your local resources. That's so important. So these are wonderful federal resources that will connect you with local resources. And you can see there's news, memberships, webinars. There's a lot of rich opportunity here. The question is, who's got time for all of this? I mean, we're all so pressed now. Next slide, please. But if you're thinking about these social prescriptions, this is where you go to look for things. This is a wonderful tool, and it's this elder care locator, and this is a small. The top, and you see on top of the screen, you put in your zip code, and it'll push you out to local resources. And this is there's better web pages for this, but you can see this is out of the Administration for Community Living, out of HHS. And if you look at this, you see that there's health resources, transportation resources, and it's very user-friendly. I've sat with older people myself and gone through this page, and it's very helpful. For professionals, there'd be more of just like punch lists, but these are very, very effective tools. Also effective tools to use with lower literacy staff people in centers, people who may themselves be working from the community in a second or third language and may benefit from real direction like this. And you can teach people how to use, those of you who are doing training, how to use these resources. Next slide, please, Ariel. National Council on Aging, fantastic resources. I think this is if you're not using it already, it's something to put in your toolbox. And again, all of these will be available after the webinar today. Next slide, please. And what I'm gonna, this is AARP. I'm gonna dive a little deeper here because this is a pretty straightforward use. But if you notice here, right on the bottom 3 lines, loneliness, also known as subjective isolation, denotes how people perceive their experience or whether or not they feel isolated. It's perception. So just because someone's in a crowd, they can still perceive themselves to be lonely or isolated. Next slide, please, Ariel. So this is what I like about this, transportation challenges. So it's clearly a cause of isolation, and this was all developed pre-COVID, but now it's different as well. But it not only gives you the problem, and driving retirement is a huge issue for people who drive in different parts of the country. I grew up in an urban area, so it was initially hard for me to understand that. And then I lived in Utah for 3 years, and wow, did I understand what the impact of driving retirement. And then if you, what can we do? These volunteer-based ride programs, age-friendly community initiatives. What would you add to the list in your local setting, in your local community? And this is this notion of coming up with social prescriptions. Next slide, please, Ariel. I'm going to go through a few of these. Poor health and well-being. This is something we deal with. Chronic disease. What do we do? Fall prevention programs. Those are very important. Chronic disease and self-management. But this notion of untreated hearing loss, that's very important and something to consider as well. What resources do you have locally? That's the hard part, is being able to, we screen or we detect for these things. How can we connect people? Next slide, please, Ariel. And you can look through these. It's just, when people leave the workforce, they lose a partner or friends die off. We see a lot of that. Or becoming a caregiver. It's not uncommon now to see 70-year-olds caring for 90-year-olds. It's not uncommon at all. And who's caring for who is a question sometimes. It gets risky. And this notion of support groups, senior centers, creative, artful aging, any of you in PACE programs, those sorts of this comprehensive, integrated care that goes into maybe you have a rec therapist on staff, things like that, but also referring people out to the community opportunities as well. Next slide, please. Social barriers, I'm just going to go through these quickly. Next slide, please. Lack of access and inequality. These are tough. Poverty, rural living, and then marginalized groups. What can we do with this? And these are, these responses are hardly adequate, but I think in your own local settings, you have to really take on these tough issues and see how you're going to address it. And sometimes this is where the AAAs will be very helpful, the elder care locators, which again, we're talking about people 65 and older. I'd like to think of people 50, 55 and older sometimes as well, especially when people are living in poverty. Next slide, please, Ariel. And this is specific. This is another AARP resource, and this one is specific to COVID, and it's recently put up. But if you look at these, they always have nice graphics. But if you look at these, you click on Get Help or Give Help, and it's an opportunity for volunteering. Somebody's lonely. Hey, do you want to volunteer? Before his death, when my mother died, my own father really suffered from social isolation and loneliness, and I managed to get him a volunteer position at a local hospital, and it changed his life. And he didn't do a lot, but it was something every single day that he was able to look forward to. I mean, just to think about things about not only getting help, but giving help sometimes people are capable of that. So let's go into this a little bit. Next slide, please, Ariel. So you click in and you can see how these work. It's straightforward. If you want to get calls from somebody, you can join a group or you can start a group. So these are the kinds of prescriptions for community services that people can get involved with or build up. Now, in your own local community, there may not be, some of you may be in rural communities where there's, next slide, please, Ariel. Next slide. That's it. So I love these maps, and what happens if there's nothing nearby, or if there's something nearby, but it's not appropriate for your patient? Sometimes you can build capacity. If you have a large enough panel in your clinic, maybe you can get more people involved and maybe collaborate with other providers in the area to develop a stronger network. Go back to, please, Ariel. To start a group, maybe think of it that way. But the idea is it's really important that we get creative. Next slide, please, Ariel. We'll go back to the, and just very, very straightforward. You can, ways to get calls for people. And this could be very helpful. Now, there's a risk here as well, because we all know there are a lot of unscrupulous people out there, potential scam artists who could take advantage of elders. And that's something that you and your teams and your organizations have to consider as well. But this notion of doing it through AARP is, or an organization like AARP, is very helpful. I don't have anything in here about church groups, synagogues, mosques, or faith-based communities. But if you're fortunate enough to have a strong faith-based community in your area, that your elder population, your older people would be willing to be referred to, you're very fortunate, because they can be very, very effective and very powerful in providing supports for individuals. Next slide, please, Ariel. And I think this is wonderful. It reminds me of Martin Luther King quote, and I think that it's apropos today. And if we go back to that Bob Butler's 1969 definition, declaration of ageism epidemic in the United States, I think that has great value. and this is my own personal value, and I don't mean to impose it upon you, but our elders are very precious creatures, and I think it's very important that we think about the way we treat them. So with that, I thank you very much. And if there are anything that came up in the chat, I'd like to hear it, please.
Wonderful. Thank you so much, Dr. Miramaldi. We did have one question I wanted to bring up from the Q&A. There was a participant who was curious around isolation of ethnic minority older adults whose primary language is not English, and kind of a question around what's the role of acculturation and how can we develop appropriate programming for their needs if they don't currently socialize with other groups in their social network. So I think that you had mentioned a few things through the presentation that you might want to end up repeating, but wanted to see your thoughts around that.
Yeah, that's a great question. And it's something that many of us have struggled with and will continue to struggle with. I do like to think about, in terms of acculturation or socialization, it's bi-directional. One culture, we think about the elder moving into this new culture, but maybe this new culture, this established culture, has to move a little bit too. And this is where community centers, for example, elder centers, might be able to have some sort of programming that people can participate in without language. The other issue, though, is the elder, her or himself, may not want to do that, and that's very important as well. So, it's something that's, I think that it's delicate. But think about bi-directional acculturation. Was the term acculturation, Ariel?
Yes.
Think about bi-directional acculturation. It's not just about somebody landing in the new culture. It's about the new culture moving a little bit in that direction as well. And that's the short answer.
Yeah, no, I think that's wonderful. Thank you. I don't see other questions, although we will give it another moment or two since we have the time. But for those of you who are wanting to hop off, we thank you so much for your time and participation. Once you close out this window, you will be directed to a quick evaluation. We would love for you to participate in that. It helps us to shape our future training and technical assistance activities. I do think we have one more question. It looks like, so someone's just kind of wondering generally some tips that folks can utilize for older adults dealing with social isolation. I mean, it sounds like it's going to be pretty community dependent, Dr. Miramaldi, to what you were saying. So I think that there's probably quite a few resources that are linked through these slides that you would be able to utilize. And I know that there was a lot of information, so you can take a look back at this slide deck when it's emailed to you and see if there are any screening tools or any resources you can utilize in your health centers or organizations. So, again, Dr. Miramaldi, I think the question was kind of just generally if there were any other tips, but I think that there was lots in the presentation, but certainly it's not easy when older adults are dealing with isolation, and it might not feel so straightforward when you know that folks are struggling with this and wanting to know kind of the first steps in helping to address it.
I really think it's important to use those federal resources, and those federal resources, you start there if you don't have anything yet, but you start there. They're excellent resources, and they'll connect you with local resources and state resources in many cases. So, it's a lot of legwork, but it's worth it. It's absolutely worth it to have something to prescribe, a social prescription.
Wonderful. Yeah, so just for folks who are still here and say they don't see the survey, Juliet can put the link to the actual survey in the chat box, but you will receive it in the email as well. And once you actually close out of this webinar, or once we stop the broadcast, it should pop up for you, just in case that's confusing. So I think we're going to leave it here. Again, for those of you who are still here, I know many have dropped off due to other engagements. We thank you so much for your time and participation, and a big, big thank you to Dr. Miramaldi for his time.
Thank you all. Yeah. No, thank you for all the wonderful work you all do.
Yes, and we'll be in touch with all of you. We hope to see you back in this virtual space for a future training opportunity. Hope everyone has a wonderful afternoon. Thank you so much.
Thank you, Ariel.